Good morning, everybody. Welcome to the first grand rounds of 2025. Great to see everyone back. We've made it through another year, right? And now that our first years have got the caffeine, we're ready to rock and roll. I was trying to show here's Nelly. So, pleasure to introduce Dr. Best. Dr. Best is an associate professor on the CT track here in our department. She went to medical school here and residency here as well. She did a fellowship at University of Minnesota between medical school and residency, research fellowship in endourology. Following residency, she did a fellowship at UT Southwestern in endourology and minimally invasive surgery under Peggy Pearl and Jeff Kadadu. And then she came back in 2011, I believe, and joined the academic staff here in our department. Dr. Best is an expert. Come on in. Sorry, team. Come in. Dr. Best is an expert in nephrolithiasis, kidney stone disease, nationally and internationally recognized by both the Endo Society and the AUA, and has spoken both within the U.S. and overseas on a variety of topics. So it's a pleasure to have her here this morning with us, giving her talk on nephrolithiasis.
Thank you, Dan. Oh, that's loud. Well, this room is certainly a blast from the past for me. Is that still okay? I think that might be better.
Yeah.
Okay, let's try that. When I was a medical student here at UW, lots of departments had their grand rounds in these two rooms here in the hospital, and so I have a lot of fun memories associated with that. So it's good to see everybody in person and talk about a favorite topic of mine, medical management of kidney stones. First, my conflict of interest disclosure. So as many of you know, nearly 2 years ago now, I became the medical director at Litholink, which is a division of LabCorp. And we do 2 tests at this lab, 24-hour urine testing and then kidney stone analysis. So that's important to know. And over the next 45 minutes or so, I hope to try to demystify a lot of this. I think this is a topic that I have heard over the years from lots of urologists, causes a lot of anxiety, and people feel like it's super complicated, they can never learn it, patients don't want to do it, things like that. And I hope to make it a simpler approach for people and show you, really there's not that much to learn to be able to do the majority of this. It's really, for the most part, 2 drugs that we use, 2 prescription medications that we use to manage the great majority of patients. The dietary recommendations are cohesive with many other dietary goals that our patients have, and following a heart-healthy diet, drinking plenty of fluids. And then most importantly, it's effective. So patients who have stones, this can be a very negative experience for them, cause a lot of suffering. But patients who are managed medically can experience significant improvements in how much of their life is affected by this. Potassium citrate, taking calcium stone formers, experienced an 80% remission rate when they were given long-term therapy. And those who were prescribed thiazides in one classic study went from making almost 3 stones a year to almost 0. So these treatments are highly effective, and it's worthwhile because of the commonness of this disease for us all to have some familiarity with it. So in the next few minutes, we're going to talk a little bit about the epidemiology and pathogenesis of stones, focusing most of our talk on a guidelines-based approach for the management of calcium and uric acid stones, as well as follow-up of stone formers. What I'm not going to talk about today, but I'm happy to talk about at any other time, are infection stones and cysteine stones, given time limitations. So first of all, epidemiology. The NHANES data is showing us that there has been continuously a linear increase in the prevalence of stone disease. Good morning. And now it affects about, the most recent analysis of this data shows about 1 in 10 Americans is going to experience a kidney stone over the course of their lifetime. And if you, as we all know, patients may often form more than 1 stone. And so this is really burdensome, both for our healthcare system and most importantly for patients. Traditionally, we taught that men were far more likely than women to experience stone disease, but that gap is narrowing, probably related to the prevalence of metabolic syndrome and diabetes, but we don't know entirely. And white Americans have the greatest incidence of stones in our country. Most of my talk is focused around the AUA's guideline statement on the medical management of stones, which was first brought out 10 years ago, more than now. And this was reviewed in 2019 and the validity confirmed. And this is a great, easy to read resource that I would suggest everybody can go to if they have questions and they're trying to manage patients. So just like any type of patients that we're trying to manage as healthcare providers, the beginning of the evaluation of a stone former is going to involve getting a good history, doing pertinent testing. But for stone former specifically, the guidelines have us make the judgment based on this information. Is this patient at high risk or low risk of recurrent stone disease? Patients who the guidelines state are low risk are first-time stone formers who have no family history of stone disease and who do not have any of these medical conditions or comorbidities that can increase their risk of forming future stones. We'll talk about many of these over the course of my talk. On the other hand, high-risk stone formers are anybody who presents with more than one stone at their initial presentation or has recurrent stones. Any pediatric patients, those who have a solitary kidney, because it's higher stakes, of course, right? If they drop a stone into the ureter and become obstructed, then it's very high stakes. And then a first-time stone former who doesn't meet those criteria discussed in the low risk. People who are low risk undergo what the AUA describes as the screening evaluation, while those who are high risk undergo the fancy-sounding metabolic evaluation. The screening evaluation includes both history and lab tests. And so the history, again, just like any evaluation that we do of patients and are taught in med school, we want to get a good family history, a dietary history, find out, are there foods that this patient eats nearly every day? Are there alternative goals that they're pursuing by what the foods they are eating? And then getting a good medical history, again, focused around these comorbidities that can, for various reasons, raise their risk of forming certain types of stones. And then the laboratory testing of low-risk patients includes first getting a basic metabolic panel, so serum labs that will give you a sense of their electrolytes, their acid-base status through their CO2 level, measurement of their renal function, and glucose to see if people are hyperglycemic. And then the AUA recommends getting a calcium in everyone as well as a uric acid. And they state that you should consider getting a parathyroid hormone level if primary hyperparathyroidism is suspected. In terms of urine testing, a straightforward urinalysis is what the AUA recommends for the screening evaluation. And potentially the pH information obtained on a urinalysis can show if the patient has particularly acidic urine, they may be at higher risk for forming uric acid stones, whereas if they have a very high urine pH, it may be suggestive of infection. Urine culture looking for urea splitting bacteria can be very helpful, as well as you're trying to figure out what's going on. The medical history questions, again, we're going to discuss these more in detail as we go through, but medical history information you want to gain are focused on GI disease. Does the patient have a malabsorptive condition? And this could be related to even unsurgically managed Crohn's disease or ulcerative colitis or severe celiac disease. People who've had a bowel resection, a colectomy, or in particular if their terminal ileum has been resected or used to make an ileoconduit, for example, or gastric bypass surgery. History of gout and hyperuricemia can put patients at risk for extra uric acid in their urine. People with bone disease, if you have disease affecting your bones and you're breaking down your bones constantly, that's a large filtered load of calcium for your kidneys to deal with, and you may experience hypercalciuria. Metabolic syndrome can be associated with low urine pHs. We'll talk about recurrent UTIs, renal tubular acidosis. We'll talk about, and then primary hyperparathyroidism and sarcoidosis can be associated with hypercalcemia and therefore hypercalciuria. You also want to review their medication list. So are these patients on any supplements or medications that may increase their risk of forming stones? High doses of calcium and vitamin D beyond what the patient needs for the RDA of calcium in their diet can sometimes be excreted. We'll talk more. High doses of vitamin C. Vitamin C, as we'll talk about, can be converted to oxalate in the urine. Medications that are carbonic anhydrase inhibitors, such as acetazolamide and topiramate, can create an RTA-like picture and raise risk of calcium phosphate stone formation. And then uricosuric agents, furosemide can cause hypercalciuria. And then there are medications like triamterene and protease inhibitors, which they themselves or metabolites thereof can actually crystallize in the urine and form drug stones that are a unique risk. So again, this is the screening evaluation. You go through this when you're evaluating a first-time stone former. And if you find they meet these criteria, then you can say, my workup is done here. The AUA actually doesn't provide specific recommendations on what you should tell the patient to do in terms of their management going forward. But in general, it makes sense to encourage people to drink plenty of fluids, enough to make 2.5 liters of urine a day, and follow a heart-healthy diet. So one that's low in sodium and animal protein, and is the expected normal RDA of calcium in their diet, not too high, not too low. On the other hand, if they don't meet these criteria and you judge that they're high risk, these folks undergo the metabolic evaluation, which sounds fancy, but it's really just the screening evaluation plus a 24-hour urine. So we're going to spend the majority of our time talking today about how to think about that 24-hour urine. So I thought, first of all, it would be helpful to talk about when you order a 24-hour urine on your patient, what does that mean and what happens as far as the patient's concerned. So most patients in the United States, if you order a 24-hour urine, it's done via one of the several commercial labs in the country. And that's because doing the citrate and oxalate assays are sort of finicky and have expensive reagents. And so it doesn't make sense for a hospital that's only going to do a few 24-hour urines, a day or a week to invest in that process. And so most are ordered via commercial labs. And when you place that order, the patient gets sent a kit. And so that usually is going to contain a big jug that they are supposed to collect all their urine in. And then typically a preservative so that bacteria don't grow in the urine while that's being collected. That may be already in the jug or it may be sent in a separate vial. It's going to include instructions and a website for people to go to get more information, often video instructions, things like that. As well as a data sheet to tell where the patient should record what time they start and finish their 24-hour collection, because every lab adjusts that to a 24-hour period. And then finally, patients at commercial labs, we don't want to receive your 3 liters of urine in that big jug. That's a lot of money to ship and a lot of biohazard material to deal with. So the patient is instructed to shake that up and pour off 1 to 3 aliquots. This is an example of the litholine kit, where you pour a small amount of urine into a smaller test tube, and that gets picked up and shipped overnight to the lab that's going to run the test. So while you don't have to be the exact expert on the wherefore and how-tos of how the patient performs the actual collection, the lab should provide that information. What I do think that we don't think about necessarily enough is how we want to instruct our patients on how we want them to perform the collection. And so I'd like to give a few examples of this. So do you want your patient, if they are still working full-time, do you want them to do the collection on a work day or on a weekend at home? Or do you want them to do both? And so that's important. And here's an example case. So this patient, 50-year-old man, still working, has recurrent calcium stones. And he, like about 15% of patients who do their first time urine collection, was asked by his provider to do a 2-day collection. And as you can see on the first day, July 29th, he had a great urine output, over 3 liters of urine. His urine pH was a little on the low side, probably because he consumed a ton of protein, animal protein, as we can see by the sulfate, UUN, and uric acid. And it was a very salty meal, so maybe he went out to eat something like that. On the other hand, you might not even think that this is the same person if you had seen these 2 urine collections not on the same graph. The next day, he only made about 600 cc's of urine. His urine pH was more respectable, as was his sodium and all those other factors. So what's interesting here is that Sunday was the first day and Monday was the second day. And so if you hadn't specified to the patient, I want you to do this and go through the potential hassle of hauling this to work and doing your collection there, you may see completely different risk factors. And if somebody's working 5 days a week, I'd argue that 5/7 of the time, potentially, their urine is looking like this. And so maybe that's what you want to see in order to manage this patient. So here, it might be that just dramatically increasing his fluid consumption might address his stone formation problem. Whereas if you only had the Sunday one, you might think, oh, this is somebody who's, daily eating way too much sodium and animal protein, and that's where the focus of my counseling needs to be. And so if you don't tell your patient, they are most likely going to do this on a Sunday. And I know that because we receive the most 24-hour urines by far on Tuesday in the lab. And that's because people start the collection Sunday morning, finish it Monday morning, and then have FedEx or whatever come pick it up, and it gets overnighted to the lab. So if you don't tell them, they'll do it on the weekend. And maybe that's what you want. I'm not saying that that's wrong, but it's just something to think about so that you get the right information that you want to be able to manage your patient. And then, do you want them to take their supplements? Another case here. So this is a 69-year-old woman who has a history of infection stones, and she does her first 24-hour urine, and you get the results back, and you look, and I want you to be like, holy smokes, that is a ton of oxalate in this patient's urine. That is a scary number. This level of oxalate in the urine could be associated with renal failure. That's bad news. And so you might be thinking to yourself, oh my gosh, I thought this lady had struvite stones, but maybe she's got primary hyperoxaluria that's been undiagnosed or something like that. Well, in this case, this patient happened to be on a vitamin C supplement, and she did not stop it. And vitamin C is converted in the urine to oxalate. And this can happen up in your kidney itself. So, your renal pelvis urine, if you will, if we were to measure it, if you have high amounts of vitamin C that you're taking in, it can happen there. But this process can continue to happen in that orange jug during that 24 hours that the patient is collecting their urine and the shipping time. And so and this highly occurs at a high urine pH. So people who have infected urine, the results can be wildly off, unfortunately, for a variety of different things, but vitamin C is a big one of them. So probably this patient's actual kidney urine does not contain this much oxalate. This has occurred in the jug, but it's important to know. Similarly, vitamin C actually is a colored agent, and so it can interfere with the colorimetric assays that some of the 24-hour urine measurements contain. And keeping in mind, most herbal medications, supplements, have not been evaluated by anybody for potential interference in these assays. So in a lot of cases, it might be helpful to hold these medications or supplements, or at least to be aware of them. We don't have time to get into today the genetic basis for stone disease for the most part, but we do live in wondrous times, and the availability of genetic testing and the research that's gone into this have shown us that there's specific genes that can be identified and ordered on commercial panels from a variety of sources to look for these diseases in patients. And it's a huge part of the pediatric evaluation these days. And so this is more a resource. I'm happy to send these slides to folks to be able to see, but the phenotype that you might see with these conditions. So we're going to talk a lot about calcium stones, and that's because these are far and away the most common types of stones that people make. 70 to 80% are calcium oxalate, while somewhere between about 10 to 15% are calcium phosphate stones. Hypercalciuria is one of the most common risk factors for forming calcium stones, and that comes in 3 different types, if you will. And I think it's helpful to understand these because it helps you remember how these things happen, and not that it's necessarily critical to differentiate between absorptive and renal, but it helps you remember how to treat these patients. So primary hyperparathyroidism is a condition in which typically one of the patient's parathyroid glands grows overly enlarged and overproduces parathyroid hormone, which is one of the main sources of calcium handling in the body. And so because they are mobilizing their bones with their parathyroid hormone and increasing their gut absorption of calcium, they have an increased filtered load of calcium that the kidney sees, and then they excrete that extra calcium in the urine. Absorptive hypercalciuria is probably the most common type, and that's where the gut is overly efficient, if you will, at absorbing calcium from the things that we take in. And finally, renal leak hypercalciuria is less common, but it is a defect in the nephron itself. Normally, the 98% of the calcium that's filtered by the nephron is supposed to be reabsorbed in the proximal tubule. But in renal leak, this process doesn't happen. And so it's not reabsorbed, so it ends up in the eventual urine that's created. All of these things can lead to the same phenotype of an increased urinary calcium, but only 2 of them are associated with hyperparathyroidism. And that's important to know about because one of the functions or effects of PTH is to break down your bones and mobilize calcium from your skeleton. And that's a big deal if you want to have healthy bones. So the way that we try to sort this out, which our patient might have, is to go to our metabolic toolkit, and this is guideline supported. We check a serum calcium, and if that's high or concerning, or we just want to know, we can order a PTH. The tricky thing is you do have to order these in the same drawing because both have significant diurnal variation. So a lot of people do order the PTH and calcium at the same time as part of their initial evaluation. In primary hyperparathyroidism, we all remember this from med school, you should have hypercalcemia and hyperparathyroidism. And so that's how you sort out these patients. Those are the ones that you have to find because the other 2 can be effectively treated with thiazides. But renal leak renal leak patients have a secondary hyperparathyroidism, have a high PTH level, but they usually have a normal serum calcium level, and it's because their body is overproducing all this PTH in an effort to carefully maintain their normal serum calcium levels because that's a very tightly regulated level. So the other factors that can influence how much calcium shows up in your urine are things like the diet. So we talk a lot about sodium, a high sodium diet being associated with hypercalciuria, but something we don't, I think, talk as much about is the influence of a protein load on urinary calcium excretion. It's perhaps even more than sodium is. If you look at this, is actually a slide we created to try to summarize a variety of studies that are out there in the literature. But as you can see here along the x-axis, we have dietary protein grams per day. Sort of most Americans are going to consume around in this range. So some of these studies gave people way more protein than you're typically going to see. But as you can see, it's a pretty linear-ish and fairly steep relationship in the amount of urine calcium that you see with that load. Sodium also has an effect on the urine calcium level, but it's not quite as steep of a relationship. It sure looks like it's significant in many people, important to follow for other reasons. But protein, I think, is the underloved aspect of management of hypercalciuria. A calcium load, so eating a ton of calcium supplements every day. People often have heard of the cases of people taking 20 Tums back in the day before ranitidine, et cetera. Excess calcium that you take in by mouth can be excreted in your urine, but it is not anywhere near that linear relationship. And that's because while things like protein and sodium are very avidly, and a high percentage of them, of what you consume is absorbed by the gut, only about 20% of the calcium we take in is absorbed, and it's highly affected by things like hormone levels, the other foods that you're eating at the same time. And so there's really no way to predict what someone's dietary calcium intake is by just looking at their urine calcium, which is different than urine sodium. If you eat it, it will show up in your urine. Other things that can cause this are, apparently I felt calcium load was so important, I had to say it twice. Acute caffeine intake and sugar loads can cause a dramatic calciuric response. And then hypervitaminosis, vitamin D. We often see this in gastric bypass patients who are put on this and have a high amount of vitamin D stored in their adipose. And then the final thing I want to make a point in hypercalciuria is that it's not as if there's some switch that goes off at once your urine calcium hits 200 or 250, where all of a sudden you had no risk of forming stones and suddenly everybody with a urine calcium of 250 makes them. These are continuous variables, all of these things that we talk about in the urine. And some excellent work again from the NHANES data shows that the risk of forming stones actually significantly goes up well below these normal cutoffs that we use in the reports. And so it's important to know as you're trying to manage patients, especially if they continue to form stones despite medical management, that this can be a source. Thiazides are the mainstay of treatment of patients with hypercalciuria, and they can be used effectively in both absorptive and renal leak hypercalciuria. That's why you don't have to try to figure out which of these your patient has if you're trying to decide whether to use a thiazide. And how do they work? They actually augment the calcium reabsorption in a different part of the nephron. And so they actually correct the underlying defect in renal leak hypercalciuria, and they compensate for the defect in the absorptive formulation. Important to know is that patients who continue to consume a high sodium or protein diet while taking a thiazide, that blocks the urine calcium lowering effect of these medications, and it can really set people up for hypokalemia. High sodium diet with taking a thiazide is one of the quickest way that you can land somebody with a perilously low serum potassium level. So important to watch for. Here are the list of medications that are considered to be thiazides or have thiazide-like effects. Hydrochlorothiazide is a twice-a-day medication, and indapamide and chlorthalidone are nice because they're longer acting. I love talking about the New England Journal study on thiazides, but I had to cut that for time's sake. But I can give you a whole 45-minute lecture on why I don't think that study was designed in a way that could answer the question or come to the conclusions that they came to. And I actually think that the study shows that the benefit and decrease in urine calcium on the appropriate levels of dosing of these medications. Medication side effects from thiazides, again, hypokalemia, hypocitraturia, hyperuricasuria, and hyperglycemia, and all of these can be monitored over the course of treatment. Let's shift gears to talk about hyperoxaluria. This is a far less common risk factor, and so while it gets a ton of press, if you will, nearly every stone patient, if you were to survey people, could tell you they're not supposed to eat spinach. Never mind the fact that the number of Americans that are eating spinach on a routine basis has to be vanishingly low. But oxalate can be a significant cause of stones. We'll talk about the three different sources of hyperoxaluria. Primary hyperoxaluria is a genetic condition, congenital therefore, due to a hepatic enzyme deficiency. And these patients typically have an early onset of hyperoxaluria and may present with stones, or nephrocalcinosis is also really common. And unfortunately, up to 50% of patients historically would end up on dialysis by age 15 if they weren't managed. But those of us who are adult urologists, we're not off the hook. It's not like all of these people are going to be picked up before they get to us because they're already on dialysis. About a fifth of patients may only experience periodic stones over their lifetime until they're an adult and may be diagnosed at that time. And traditionally, for years when I gave this talk, it was a sad story. The only treatment that we had for these folks was a combined liver and kidney transplant, first to provide them that enzyme making capability in their liver, and then to address their boxed kidneys. But a huge change or development in the medical management of stone disease and a triumph of science, I think, was the development of a new class of medications, RNA interference agents, which here in the US are lumasiran and nedosiran, which are indicated for primary hyperoxaluria type 1, which is the most common. Lumasiran came up first, and it targets glycolate oxidase, and a double-blind placebo-controlled trial, that was what was submitted to the FDA, showed that 65% of these people had normalization or near normalization of their urinary oxalate levels. These are people who were excreting, 100, 150 milligrams per day of oxalate in their urine and boxing their kidneys. And this is amazing that this has developed. Is that now patients can get a once-a-month injection that essentially cures or treats this problem. Nedosiran has a different mechanism, but is also an RNA interference agent. The FDA trial for this showed 50% of patients reaching normalization of their urinary oxalate. But endogenous production, as shown here, is one source of the oxalate that we make. Even if you consume zero oxalate in your diet, you will still excrete some oxalate because you, if you don't have pH, or if you do, sorry, you will make this in your body. But oxalate itself is also taken in from the diet. It's not very avidly absorbed. So only about 10% of the oxalate that we consume in our diet is absorbed through our gut. But if you eat enough of it, even 10% can be a lot. Oxalate-rich foods can be a source of people having significant hyperoxaluria, as can having a calcium poor diet. Say somebody is a vegan or lactose intolerant or just doesn't like dairy foods. It is also possible that they may be consuming a medium amount of oxalate-rich foods, but have so little calcium to bind it in their gut that they can have the same issues. And we can't talk about hyperoxaluria without talking about the important work that's been done at our own very institution, the charge led by Dr. Peniston, who has really advocated for not telling every single stone former that they should follow that they shouldn't eat any oxalate-rich foods. And that's because she has shown, number one, you don't have to do that in order to normalize oxalate or reduce oxalate in the urine. You can put people on a calcium supplement and have a very similar effect in reducing urine calcium. But also, oxalate-rich foods tend to be very healthy foods. So spinach, nuts, things like that, that we want patients to be consuming otherwise. A lot of fruits and vegetables can also contain this. And reducing those in the diet can actually make the diet less nutritious. And a lot of these foods also contain stone-friendly things, such as magnesium, fiber, and an alkali load. And so I think across the board, telling patients that they should reduce the oxalate in their diet is not particularly helpful because, again, not many of us are eating a huge amount of spinach every day. So I advocate for asking patients, what do you eat on a routine basis? Is there something that you eat nearly every day? And if you have a patient who is a juicer or makes smoothies and they are putting a lot of these foods every day, this can be a potential target for adding calcium to this, or perhaps switching it out a bit, what they include in these smoothies. We've also seen cases where patients are eating a huge amount of nuts every day, and that can cause hyperoxaluria and high sodium load in their urine. That's a far different situation than the person who thinks they're making a big move and improving their diet for stones because they stop eating the amazing strawberry rhubarb pie their wife makes twice in the summertime when those ingredients are fresh and wonderful in Wisconsin. So I think, meeting your patients where they're at, and it's pretty simple actually to ask people, is there anything that you eat on a daily basis, to try to flesh out this kind of information. Another way that too much oxalate can end up in the urine is patients who have malabsorptive states and have diseased bowel. So this can be associated with any condition where somebody has chronic diarrhea, and people who've had significant bowel resections or gastric bypass weight loss surgery. And important to point out is you have to have an intact colon in order to have technically enteric hyperoxaluria, which we'll talk about. That's where the pathologic absorption occurs. The way that this works is actually twofold. So people who have chronic diarrhea end up with fat malabsorption, and that means that they have excess fatty acids in their gut. Fatty acids, if you think back to med school, those are negatively charged anions that are then floating around in our intestine, and they're looking to come to stability and bind with cations, which in our diets tend to be calcium and magnesium ions. And so when they avidly bind, because their presence is very high, they bind that all up. That means that there's less calcium and magnesium available to bind to oxalate in the gut. Oxalate and calcium bound together in the gut is a good thing because that's not transported across the gut lumen easily. That gets put out in the stool. But if free oxalate is floating around, that is more avidly absorbed by the intestine, and so they can end up with hyperoxaluria. The other aspect of this is that fatty acids do not belong in the colon. They're almost always normally absorbed fully in the terminal ileum in the small intestine. And so if fatty acids and bile salts end up in the colon, this is really irritating to the colon, and the permeability of the colon is affected. And it makes it so that the colon, which normally does not absorb oxalate, is able to absorb oxalate, and that leads to this hyperoxaluria. This process is classically called saponification, a cation forming with free fatty acids. Additionally, people who have chronic diarrhea are at risk for other sources of stone formation, such as volume loss and low urine output if it's coming out in their stool instead. The metabolic acidosis associated with chronic GI disease is a risk factor, as is hypomagnesuria. Shifting gears, trying to swiftly move through here, let's shift gears to talking about hypocitraturia. So unlike calcium and oxalate in the urine, we want high levels of citrate because citrate's protective. It binds or chelates calcium ions in the urine so that it doesn't bind with oxalate, for example, or phosphate. And it also inhibits crystal nucleation, which is one of the critical steps of stone formation. There are a variety of conditions that can be associated with a low urine citrate value. A lot of these are metabolic acidosis. So really any cause of metabolic acidosis chronically can cause low urine citrate. So GI causes or renal tubular acidosis. So the type of renal tubular acidosis that we need to know as urologists, because they can form stones, is distal RTA or type 1. And normally what the body has to process an acid load every day. So the byproducts of metabolism are acidic. The diets that we eat tend to overall contain a net acid load. And so our kidneys have two ways to excrete acid, both in the form of NH4 or ammonium in the urine, and then also as titratable acids, which I essentially think of as protons or the pH of urine. So a normal response to a meal or any cause of acidosis in your body, and remember, your body is going to fight super hard to have a normal serum pH. It's really bad if something's really bad going on in your body. You're really sick if your pH gets out of whack. And so if you can't do this, if you can't dump protons in your urine, and the only way you can excrete it is ammonium, then you can develop an acidosis related to this. And so that's the defect in these patients, and they have a high pH after an acid load. I like to group things together in my mind for how to remember things. So just like in a urinary diversion, these people can end up with a hypokalemic, hyperchloremic metabolic acidosis. Other potential causes we already talked about. Thiazide medications can cause this as a side effect, as can hypokalemia of any cause. And the management, again, we can start with dietary measures, such as trying to add citrate-rich foods to our diet. So lemon and orange juice have been used to show a significant increase in urine citrate. The challenge here is that lemonade and orange juice often come with a lot of sugar to make them palatable, and that's high calorie, and most of our patients don't need to be told to drink liters of high calorie beverage. But vegetarian diets, it's rare to see a vegetarian who has a low urine citrate. So lots of fruits and vegetables overall can contain an alkali load, which can increase urine citrate. If diet is insufficient, we can prescribe patients alkali load, which is typically and traditionally in the form of potassium citrate. This exists as slow release tabs. Typical starting doses 1 to 2 tabs 2 to 3 times a day. And then there's also a liquid formulation of potassium citrate that we should think about in our patients who have GI malabsorption or fast GI transit times. They may be able to better absorb this than a slow release medication. And then a shout out to sodium citrate or sodium bicarbonate baking soda. Yes, the cheap stuff for $1 in the orange box. A lot of the work here studying this has been done at this very institution. And this is a super cheap way for people to add both alkali to their diet and to have it be more palatable for some people. And it's super cheap. The effects of taking out an alkali load, either potassium citrate or sodium bicarbonate or one of the other forms of alkali, it can both increase your urine citrate, and it also raises your urine pH. In a lot of patients, as we're going to talk about, that may be a benefit. Acidic urine pH can be its own risk factor for stone formation. But we do have patients who already come to us with a high urine pH. And so we want to be cautious if somebody's diet, for example, is already giving them a high pH to not overshoot. You don't want to push somebody who's a calcium oxalate stone former, give them too much alkali every day and have them start forming brushite stones. That can be a miserable effect for them. So monitoring for that. The one exception to this is RTA and metabolic acidosis patients. There, the provision of alkali is the standard of care for anybody with metabolic acidosis. You have to give these people alkali until their serum CO2 normalizes. Because again, your body is going to sacrifice nearly anything, your bones, anything to try to get your pH back to normal. And so the potassium citrate is the mainstay of treatment for these patients. And so Dr. Preminger's small but classic study treated 9 patients with incomplete RTA. So these people actually had a normal serum CO2 level, but treated them with this despite their pre-existing high urine pH, which is seen in RTA. And they found that these patients actually made fewer stones despite an increase in their pH. All right, in our last few minutes, we're going to try to cover hyperuricasuria and uric acid stones. So elevated urinary uric acid, this causes one of, I think, the classic confusions in the management of stone disease. And it's because the words, you would think you have too much uric acid in the urine, right? You probably must make uric acid stones, but that's not the case. Uric acid stones, as we're going to talk about, come from low urine pH. We treat that with alkali, typically potassium citrate or baking soda. We care about hyperuricasuria because it's a nidus for calcium oxalate stone formation. It's sort of as uric acid crystallization is sort of like the grain of sand inside an oyster and the pearl being your calcium stone. And so decreasing this can be a significant benefit to patients who continue to form calcium stones in particular. Again, we can start with diet. So the majority of the uric acid that we see in our urine comes from dietary intake of animal proteins. They tend to be high in purines, which get metabolized into uric acid. So asking people how much meat they're consuming, how much seafood that counts to, and asking them to consume 8 ounces or less is standard of care. If that's insufficient, then the next step is to alkalinize their urine for reasons we're going to talk about. But uric acid is super soluble at even medium pHs. And so that will allow people, even if they continue to have a high uric acid in their urine, they will have an improved solubility of that if you can't form that grain of sand. And then finally, allopurinol can be used typically in calcium stone formers, especially if they have gout or hyperuricemia as well, or if they continue to make calcium stones despite other treatments for hyperuricasuria. And then let's talk about uric acid stones. So again, the cause of uric acid stones is low urine pH. Most uric acid stone formers, if you look at their 24-hour urine, they have a normal urinary uric acid level. It's because of the solubility characteristics, the pKa, if you will, of uric acid, that it becomes an issue when your urine is too acidic. Most commonly, traditionally, we'd say it's idiopathic, but we see more and more of this in patients who have insulin resistance, can have impaired ammoniogenesis, and end up with a low urine pH. So this is one of my favorite graphs, and it looks really busy. You know, it's got these 3 axes. It makes it look complicated, all these different bars. It seems complicated. But what the whole point of this graph is trying to tell you is why we choose pH manipulation in these patients to treat the hyperuricasuria and low urine pH rather than tackling the amount of uric acid in the urine. And that's because if you see, even if people who make uric acid stones, they're typically going to present with pHs in this range. And even normal 400, 600 milligrams per day of uric acid is going to be above the solubility level of uric acid. And it's going to be crystallizing in the urine, no matter how little protein you tell somebody to eat, etc. But if you can get their urine pH to this 6.5 range, look how much uric acid you can manage to dissolve and below the solubility level of uric acid. They can still be excreting 1,200 milligrams per day of uric acid and still keeping that in solution and not crystallizing. So that's why we target that for both hyperuricasuria and calcium stone formation and low urine pH. It's incredibly effective. It can actually be so satisfying to have a uric acid stone former. And these are the people that you can potentially really cure. If you can get them to get their urine pH above 6, in many cases, they may dissolve the stones that they have and go on to never form another uric acid stone again, which is amazing. So we're coming to the end. Guidelines in the AUA guideline statements do have a few recommendations about how to follow these patients. Again, the people who you've determined to be low risk, the guidelines don't give us a lot of suggestions on how to follow those people. But if you are managing a high risk person and have done the metabolic evaluation, they recommend repeating a 24-hour urine within 6 months of any initiation of dietary change in medical therapy. And that makes sense, right? If you're going to take a pill every day or make a drastic change in your lifestyle, you want to know if you're doing it right, if you're on the right dose, if you're following instructions well before you wait 5 years and form another stone. And so the 24-hour urine collection can provide a short-term way to assess the effect of therapy. The guidelines also say, of course, obtain labs as needed to assess for the various adverse effects of pharmacotherapy. And they recommend repeating a stone analysis whenever stone material is available. Changes in stone composition can occur. Like I said, you can shift somebody from making calcium oxalate stones into making brushite stones if they're over-alkalinized. And so it's cheap and easy to obtain that material and send it for analysis, and it may dramatically affect your care. And then they rather nebulously say periodically obtain repeat imaging to assess for stone recurrence. So hopefully, overall, I've tried to demystify some of this. I think it's fun to do, and it's a great opportunity to make a huge difference in a condition that a lot of patients, 1 in 10 Americans, is suffering from, and that has a lot of pain and suffering and time off of work and cost to it. But we can also identify really important other doctory stuff, like other conditions like hypercalcemia, distal RTA and GI disease, things that maybe stone disease is just the canary in the coal mine or the first presentation that you see in these patients. And that's the thing that brings them to the doctor. And you can identify, hey, there's something else that might have a significant impact on their overall health beyond just stones. And you can start the initiation of that diagnosis. Stone meds, we can use potassium citrate for lots of risk factors in stone disease. You can give it in patients with low citrate, low urine pH. It may even be beneficial in patients with hypercalciuria. Thiazides, get to know it, become comfortable with one, dose it appropriately. Make sure to check BMP within a few weeks of starting it to look for that hypokalemia and hyperglycemia. And keep in mind, it is guideline supported that you can use these medications and treatments even if you don't have a 24-hour urine to base it on. So say you have prescribed, ordered your patient a 24-hour urine like 15 times and they just never managed to get it done, and they always show up to you and they're making more stones and they're miserable, but they just can't do the 24-hour urine. Or you're in a community where it's not available, or lots of different things. You can order them these therapies without having to knowing that your patient is hypercalciuric, for example, and so prescribe these, and it's guideline supportive and effective. You can get bonus points for trying to identify crazy food consumptions, or somebody's eating a bag of spinach every day, or an entire jar of peanuts. I've seen both. Considering pH testing for both patients with hyperoxaluria and no other obvious cause, and also siblings of patients who have pH. Overall, thank you very much. I'm happy to answer any questions or talk about this another day. Yeah.
Questions there. Thanks a lot. So it's interesting that stones and urine in the same group. Yeah, physiologically it's changing. So what is it?
Well, it is potentially changing, right? So your physiology changes when you have metabolic syndrome. So we are seeing, I'm hopeful this is the first year in a long time. I heard on the news that the average BMI of Americans has gone down. So maybe I'm hopeful, maybe we're going to see, maybe 10 years from now, we'll know that it's an indication stone disease is a reason to give somebody Wegovy or whatever, to manage their stone disease. We just don't know at this point, but your metabolism can change from these other conditions. And so we're seeing more calcium phosphate stones in kids, especially young or teenage girls. We're seeing, and we don't know why in some cases why this is happening. We're seeing more obesity in kids, which is sad, and seeing uric acid stones even in kids and other types of stones.
So these GLP-1.
So it has so far been studied in terms of 24-hour urine changes. They have not been studied long enough to know if they actually decrease like ER visits for stones or CT measurements of stone burden, but it has been shown to increase urine pH and increase urine citrates in patients, and that's separate from the BMI effects as far as we can tell, which is interesting. Lots of ongoing research there. Excellent. Good to see everybody. Yeah. Oh, yeah.
So, for how long you've been medical director for the Flint, almost 2 years ago.
Almost 2, yeah.
My question is, we always talk about lifelong learning, or learning never stops.
Mhm.
What have you learned, or what were you surprised to learn about stone disease, either at the individual or national level, since you became medical director?
Yeah, so much. First, how many primary care doctors are out there who are trying to do this work for our patients? They're the front line, and the number of other doctors who are out there who are trying to sort this stuff out, I think is fascinating. Any provider who orders a 24-hour urine from Lithiolink can call me and get advice. We can talk through how to think about stones. And so that's one of the most fun parts of my job, is getting to talk to doctors and nurse practitioners and PAs all over for how to manage stone patients. And then I think, I didn't have time to talk about it, but stone analysis was a complete black box to me really before I started working at Lithiolink. And I guess I thought, it seems knowable in stone analysis. Like if you have a substance, a stone in your hands, it seems knowable how many atoms of calcium and molecules of oxalate are there, and how many of uric acid or whatever. And so it seems like you should know exactly how much is in that, but it is no lab is able, you're not putting that whole stone into something and dissolving it and counting all of those atoms to find out the exact percentages. So there's sampling effects. So even before the sample gets to the lab, you're lasering the stone potentially in the body and pulling it out. And so it might be already affected. What if the more brittle part of that was calcium oxalate dihydrate? And so that's all floating around as dust, and you're just grabbing the hard core that remains. That's the COM stone. And so already the bias has been introduced, if you will. The measurement bias has been introduced even before the sample gets to us. And so learning how stone analysis is done has been really interesting. And we have discovered 3 new types of kidney stones this year alone. And I think so one that's already been published is pyrophosphate containing stones. And every patient so they had never been reported before, but every patient who was found to have a pyrophosphate containing kidney stone has hypophosphatasia, which is a genetic condition that can cause weakened bones and poor dentition and pathologic fractures over the course of a lifetime. And so that disease has been around forever, but nobody has noticed it in the kidney stones out there before. And so I think that's a huge difference for patients to be able to use stone analysis to discover these things. So that was a long answer to a short question.
That's great. Well, thank you for your time this morning. Congratulations on your work with Lithiolink. And why don't we take a few minutes and we'll bring you